Welcome to Talking Treatment, the podcast that features healthcare experts, industry leaders, and treatment center providers from around the country. Presented by AZZLY. I'm Tom Patton, and on this episode, I'm talking with Dr. Andrea Barthwell, Senior Advisor and Strategist to AZZLY. Dr. Barthwell previously served as Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy. She also served as President of the American Society of Addiction Medicine. Dr. Barthwell, thanks for joining me on the podcast today.
Thank you for having me. Nice to be here.
Let's talk about some basics here. First of all, tell me about the top 3 challenges to the patient with a substance abuse disorder today.
Well, I like to think about the opioid crisis as a part of substance use disorders. And I think the biggest challenge to patients right now is staying alive in the twin epidemics of the death from opioid overdose and COVID. COVID has changed a lot of things in all of our healthcare systems, and the substance use treatment system being part of that. It has created tremendous challenges, and we've found out just how fragile our healthcare delivery system is and how fragile the system of care is that delivers services to people with an opioid use disorder. So I think that the dual epidemics of death from overdose with opioids and COVID has created a tremendous challenge. And the fact that we are expected to socially distance and a number of providers have left the healthcare delivery system as a result of COVID means trying to get care right now is particularly challenging for people with an opioid use disorder or a substance use disorder.
Is there some kind of a correlation between opioid use and what you're seeing with COVID? Are people who are using opioids more susceptible in some way, or is it just serendipity, for lack of a better term?
Well, we know that all of the indices that we look at to determine how bad substance use disorders are and opioid use disorders specifically have gone up during this epidemic of COVID. So there's more daytime drinking, for example, with alcoholism. There's more drinking at home by young people. There's more depression and drinking for a mental health cause and using drugs. Because the EMRs have the capacity, the emergency medical response teams, the EMTs, have the ability to decide whether they are going to reverse an overdose in the community or take a person to the emergency department when emergency departments are crowded from COVID patients showing up where there are surges. Many of these reversals get done in the community. And as a result, we have the second challenge of people with an opioid use disorder, that they get reversed in an environment where there's not a law or regulation requiring a warm handoff to treatment. So if you were reversed in an emergency department in the past, the emergency department had to find services to refer you to. If your reversal takes place in the community, then those services referrals are not provided. So it delays the onset of treatment for somebody who might have been able to take that teachable moment and convert it into an admission into treatment.
Are you seeing that there was maybe a second wave of that kind of substance abuse as we went through, we have vaccines, things are going to be getting back to normal, and then suddenly there's the Delta variant, and it becomes more of a mental challenge for people, and then they fall back into the substance abuse pattern simply because, we thought things were going to get better, and now they're not?
Well, people who are using drugs voluntarily, have the liberty of using in response to external factors or not. Then if they have volitional control over a decision to use, that's one thing. But when I talk about people who have a substance use disorder or an opioid use disorder, I'm talking about people who don't have the privilege of choosing on a daily basis whether they're going to use or not. They have to get up in the morning, get organized to get the drug, to use the drug, to recover from the use of the drug, to get the drug again. So there are different sectors to be interested in. And if you are responding to the external factor of things not being normal, and wondering when things will go back to normal again, and you're using because that doesn't feel good, that feels bad, that's one thing. But I'm actually talking about people who don't have volitional control over their use again. We say that drug use is a preventable behavior, but an addiction or a substance use disorder is a fundamental yet treatable disease of the brain. That person who has gone from voluntary drug using to change their mood or mind to someone who has the disorder really doesn't get to modify how they're using in response to what's going on around them. They are on autopilot, and they have to use every day to avoid withdrawal.
You've kind of touched on this a little bit, but let's go into a little bit deeper about some of the challenges in the treatment system as a result of the COVID-19 pandemic.
Well, as a provider, people needed to figure out how to protect themselves. And many treatment facilities shut down. Some got shut down because they were in a geographic location where they weren't allowed to bring in patients from the outside to be treated. Some got shut down because the programs didn't have PPE. Fortunately, the White House declared that people who worked in drug treatment were essential workers, and they were, able to get PPE and able to stay on the job after the supplies came back. And drug treatment providers were able to get in the initial round access to the COVID vaccine. Many of our employees were able to get the first vaccine or the first and second vaccine if they were taking one that had 2 vaccines. So we were included amongst those who needed to be at work. But again, many individual practitioners started doing care through telemedicine. Many states created exemptions so that you could see your patient in the state where you were licensed, but they expanded it so that you could see people in the surrounding states, because people in Chicago, for example, where I practice, fled Chicago and went to rural Michigan in order to just get more air around them and breathing room as a result of COVID. Initially, if I was not licensed in Michigan, I could still treat somebody whose feet were in Michigan, planted in Michigan when I was seeing them across telemedicine. Those exemptions have been lifted in Illinois. So now you can only see somebody who is in a state in which you're licensed. And in many instances, for example, in Pennsylvania, they're looking at losing the exemptions for telemedicine altogether. And while some of these exemptions were given under emergency rules, state legislators are saying, well, we're not going to give the authority to a single individual in an agency or office of government to say that this exemption needs to be in place. We want the legislators to think about whether that exemption should continue. And we're seeing some of the exemptions that facilitated getting treatment to people during COVID going away at a time when COVID is surging again. And we need to make sure that we keep employees who may have conditions that, COVID would be a challenge for, even if they're vaccinated, we need to make sure they stay protected. But if we can't do our treatment across telemedicine, we can't protect them adequately. And so it's a challenge keeping things going as the rules change. And the rules are changing all the time. So it's a challenge even keeping up with the rules.
Let's talk about some of the ways in which providers can and should deal with opioid use disorder. And let's start about when you're talking about with a substance abuse disorder.
Well, let's talk about with the use of medications for one.
Okay.
When Data 2000 was passed, it had a little thing in there that called for providing psychosocial services to patients who needed it. It didn't require it like it does in a methadone system, but it recommended that a physician who was treating someone who needed psychosocial services in addition to the medicine would have the ability to either provide or refer that person to services. Looking at those data over time, about 10% of patients who are entered in medications for opioid use disorder, MOUD treatment, receive psychosocial services. doctor's offices just aren't set up to provide it. They have nurses who work for them, they have phlebotomists who work for them, but they don't have social workers who work for them. And sometimes, even if they wanted to hire social workers or clinicians to do the work in their office, the states in which they operate have requirements about getting licensure if you're providing services to someone with a substance use disorder. And you have to go about getting a separate license and carrying on a lot of other reviews that you wouldn't do if you were just practicing medicine. So it prohibits the provision of these services. Additionally, if those patients are receiving public entitlements, Medicaid and Medicare for the medication part, they wouldn't be eligible for reimbursing the office for the services that the social worker provided unless it was coming through the grant and aid system in the state. So there are lots of barriers to providing comprehensive care in the doctor's office. Therefore, we have come to a point now where we see that only about 10% of patients who receive MOUD in the doctor's office receive comprehensive care. Now, there are those who've written and argued that the medications alone are curative, so you don't need the psychosocial services, but I've rarely met someone with a substance use disorder that couldn't benefit from having some talk therapy go along with the medications. And so we don't have a system that provides for it. But there are some solutions that are coming online, the prescription digital therapeutics. And there is one that is FDA approved that I can actually write a prescription for my patient to receive psychosocial counseling through a digital prescription digital therapeutic. And they can take that along with the medicine that I've been prescribing. The challenge there is this is a new area of medicine. Only one of the app-based services that is out there has gone through the FDA review. And until there's FDA review and approval of these things, we probably aren't going to get a reimbursement code for them. And right now, if you are taking that service, you're either on a self-pay basis or you're using it through their compassionate use program. So it's not widely available. I think there's a lot of potential for prescription digital therapeutics to close the gap and to be provided along with telemedicine-based opioid therapy or even bricks and mortar office-based opioid therapy to get these services to the people who need them. But there's more work that needs to be done there. And unless and until these new digital therapeutics go through FDA approval, they don't have built into them all the privacy protections that we as people in the field believe should be built into them.
What happens when you take that substance abuse disorder out of the equation? How does that change treating the opioid use disorder?
So there are people who have, singularly like opioids, use them and only use them, but rarely do we see people who don't use other substances, particularly sub-end things when the opioids aren't available to sort of take the edge off of the deficit of opioids in their life. So if you have someone who is a pure opioid use disorder, getting them into a methadone program or a medication for opioid use disorder program is great. If you have someone that's using other substances, medications alone don't address those other substances. And the person who is writing the prescription for buprenorphine in that instance has to be aware as to whether they're using benzodiazepines for sleep or anxiety or back pain, if they're being prescribed that or taking it from the street, or if they're using alcohol on their own or, smoking marijuana in addition to the opioid. And again, the buprenorphine does nothing to address those other substances. That's why, in fact, psychosocial services need to be employed and other kinds of manualized treatment that the National Institute on Drug Abuse have developed for these other disorders. So, for example, contingency management services for the stimulants has been manualized and shown to work through NIDA so that you can actually give people rewards the longer they stay off the substance. And being able to employ a variety of strategies along with the MOUD is what we have found works best in the long run. Some treatment's better than none, more is better than less, but treatment is best when it's driven by assessment. So you know all that they're doing. It's buttressed with case management, and if the person goes away for treatment, it's completely completed with follow-up care in the community. Now, MOUD is obviously treatment that takes place in the community, but the medication alone may not be enough for someone who has uses a variety of substances.
Does alcoholism change that equation at all, or what does that do in that process?
Well, alcoholism presents some challenges at the outset, because in order to stop alcohol, you generally need to have at least a medically monitored or managed system, because alcohol withdrawal can in fact be life-threatening. So that's presented some challenges in the age of COVID, in terms of bed capacity in detox facilities and bed capacities in hospitals. And there are some psychosocial detoxification programs that are run in the not-for-profit arena, where patients were asked to go through an emergency room to get certified that they could be admitted into these non-medical settings for withdrawal from their alcohol. And again, the emergency room is not a safe place to be if you're trying to avoid COVID. We don't actually have medications for the maintenance of someone like we do for OUD for alcohol. So it's abstinence-based treatment. Mm-hmm. You've got to first get them off, and then you got to get them to stay off. It's in the words of Terry Rustin, who writes about quitting nicotine: you got to quit and stay quit. People know how to quit, but staying quit becomes the challenge. And it is for tobacco, it is for alcohol, it is for many, many of the substances. And being able to figure out what is going to enable that person to stay off of drugs once they quit, or alcohol or tobacco once they quit, is what happens in therapy.
And finally, how does that equation change for a patient who is being treated for a mental disorder?
So the mental disorder can precede the substance use, or the mental disorder can follow the substance use disorder. If it precedes the substance use, and this is something that you have to sort out through history. So if it precedes the substance use disorder and the person uses substances because they've not had an adequate assessment of mental disorder and been put on appropriate medications, they may be self-medicating that. And when you take the drugs out of their system, and I use medications when I talk about it being prescribed and used appropriately by a doctor, I'll call even a medication a drug if a person is self-administering it without the service of a physician managing that. So if a person is using a substance, whether it's a medication or a street-acquired medication or a drug, to manage the way they feel from a mental disorder, and you ask them to stop, that mental disorder becomes unmanageable again. So you've got to be able to assess whether there's a co-occurring mental disorder and whether there are medications that can reduce the symptomatology of that so that the person can function. And sometimes the symptomatology of that can be reduced with prescribed medications. Sometimes the symptomatology interferes with them engaging appropriately in treatment services. So if someone has an anxiety disorder and they don't do well in groups, they're probably not going to be able to respond to going into a residential treatment facility if their anxiety is not addressed. And if they leave treatment and then don't go to 12-step meetings afterwards because they are too anxious to go, they're not able to engage in that part of their treatment plan, they may be setting themselves up not to be successful after the treatment episode. So it's important that treatment providers be able to assess both the order in which these things are acquired, and then to determine whether there are better medications than the drug that the person was using to treat the underlying mental disorder.
Now, you've used a number of electronic medical records and electronic health record systems. What do you like about the AZZLY system?
Well, the thing that won me over for the AZZLY system was that they paid attention to the provider doing medication-assisted treatment, as it was called at the time, or MOUD as it's called now, the medications for the treatment of opioid use disorders. So if you were a practitioner who had the X waiver on your DEA and you were able to write prescriptions for individuals who needed buprenorphine for their opioid use disorder, the AZZLY system was designed to accommodate the way in which you practice. And there are electronic health records that work with doctors in their offices that don't pay any attention to the particular rules and regulations that you operate under if you're treating someone with a substance use disorder, including the additional protections that have to be in that record. There are electronic health records that work with treatment providers that don't take into account how the individual medical practitioner does his or her work. The AZZLY system decided to take that on, was the first in its class to take that on, and actually does it quite well. So it's quite responsive to a physician who may be seeing people for hepatitis C, which, by the way, is surging now and has started to surge during COVID, who may be seeing people for their liver disease, but also wanting to treat their opioid use disorder. That record can be superimposed on what they're using in their office and allow them to keep the records adequately for the medication treatment of the opioid use disorder. And those of us who practice in that space know that one of the challenges that we are facing is that doctor rates are back. Before the COVID crisis happened in this country, there had been sort of a stay on doctors' raids, the doctors who were treating opioid use disorder in their office. But the Biden administration has resumed raids, and they are prosecuting specialist physicians. So we don't know, looking at it, whether this is, the prosecutors reopening cases that they were chasing before COVID, brought things to a close, or whether it's Biden policy. It's not clear because we don't see that reflected in the White House Office of National Drug Control policy strategy document. What we do know that is that physicians are being raided again. And to throw that wet blanket on a fledgling area of medicine is not a good idea. To tell physicians that you're not going to be safe if you treat this disorder in the patients who are in your practice is not a good idea. And there are, a number of physicians who have the X waiver who don't prescribe. There are a number of physicians who have it, who prescribe it to a very few patients in their practice. And there are others who have made it sort of their life's work to treat people with the opioid use disorder. And they have the maximum number of patients that are allowed under the X waiver, and they may have associated with other mid-level practitioners to treat more. Those are the practices that we see are being raided and are at greatest risk. And if you decided that you were going to go after doctors that treated pancreatic cancer, and scared medicine away from that, we wouldn't have a very happy situation in this country. And so I don't think it's a good idea to, single out and target physicians who are treating opioid use disorder with this medicine and tell them that they're at risk for being raided. And, even if they're doing nothing other than accumulating a few hundred patients in their practice. But back to your original question, I like AZZLY because it recognized how I had to modify my practice in order to treat medications for opioid use disorder. And they took that on when a lot of people wouldn't take that on. They're first in class.
Dr. Barthwell, it's been a fascinating conversation, but that is all the time that we have for this edition of Talking Treatment. So thank you again for joining me and taking time out of your day.
Thank you for having me. I've enjoyed it.
We've been talking to Dr. Andrea Barthwell, Senior Advisor and Strategist to AZZLY. Talking Treatment is produced by Broadreach Communications and AZZLY. AZZLY offers an all-in-one solution for behavioral health care and addiction treatment providers. Visit AZZLY.com, that's AZZLY.com, to schedule a free consultation with an AZZLY expert today. And be sure to subscribe so you don't miss an episode of Talking Treatment. I'm Tom Patton. Thanks for listening.